But the good thing is we're able to provide access to eye care in keeping with Canadian diabetes guidelines to populations that otherwise would have gone without any care at all.
Welcome to EyeCan, a podcast about ophthalmology through a uniquely Canadian lens with Dr. Mona Daghar and myself, Dr. Hady Saheb.
Bienvenue à EyeCan, un balado sur l'ophtalmologie sous un angle typiquement canadien avec le Dr. Hady Saheb et moi-même, Dr. Mona Daghar.
Season 4 of the EyeCan Podcast is brought to you by Bayer Ophthalmology. We thank them for their support. Nous aimerions remercier Bayer Ophthalmology pour leur support de la 4e saison du balado EyeCan.
We will share our experiences as ophthalmologists today and tackle some of the challenges we face as healthcare providers. Hey there, eye care enthusiasts. It's Mona and
Hady, back at it again with EyeCan.
You know it, Hady. Today's episode is going to be a real eye-opener, pun intended.
Mona, always with the puns. I promise, folks, today's discussion will be just as sharp as Mona's great wit.
Hey, we're here to keep it both informative and entertaining, right?
Absolutely. So whether you're a seasoned ophthalmologist or just as fascinated by eyes as we are, you're in for a treat.
Hi, everyone. On today's episode of EyeCan, our topic is age-related macular degeneration with guest Dr. Ravi Dookeran of Winnipeg, Manitoba. Dr. Dookeran has worked in Winnipeg since 2006 in the University of Manitoba Department of Ophthalmology. He is the medical director of the Waterfront Eye Institute and runs a surgical and medical retina practice serving all of Manitoba, Nunavut, and Western Ontario. After completing his ophthalmology residency at the University of Alberta, Dr. Dookeran went on to complete a 2-year surgical and medical retina fellowship at McGill University.
He is affiliated now with the University of Manitoba's Department of Ophthalmology as an assistant professor, teaching residents and retina fellows, and is actively involved in clinical research, having authored numerous publications. Dr. Dookeran has been actively involved in developing a tele-ophthalmology program and serves as the medical director of the Manitoba Retinal Screening and Vision Program, providing access to care for diabetic patients in northern and remote communities across Manitoba. In addition to being vice president of the Eye Physicians and Surgeons of Manitoba for many years, he sat on the COS board of directors as treasurer from 2019 to 2022 and continues to be involved in the COS Foundation. Ravi, welcome to EyeCan. Today, we're going to talk all things AMD. So let's go ahead and jump right in. So Ravi, AMD is, one of the most common and important causes of blindness, unfortunately. And so I'm curious to know what you find to be the most challenging aspect of treating AMD.
Thanks, Hady and Mona. Thank you for the invitation to visit with you on today's podcast. Well, AMD is still the leading cause of irreversible blindness in patients 55 years and older. Treatments have come a really long way in the past 20 years since the PDT era with the introduction of anti-VEGF agents. While these have completely changed the field for AMD management and outcomes for patients, long-term studies demonstrate that many patients still end up declining in vision over 5 years to return to presenting baseline. And that's due to the progression of the atrophic component of the disease and sometimes with macular fibrosis. The upside is that for these patients, you actually help slow down their visual decline and given them some time that they wouldn't have otherwise had. One of the other big challenges, besides the inevitability of aging, is that many of us in Canada face the same problem. We have a growing aging population, and AMD requires lifelong treatment. Even with treatment tapering or treat and extend protocols, only roughly half of the patients get to stability levels where they only have to be treated every 4 months. Many still need Q1 to 2 monthly injections or quarterly injections. And that's just AMD patients. Add in the diabetic patients, the patients with retinal vein occlusion, and the other various diseases that need to be treated with anti-VEGF So the clinics have become extremely full with frequent, regular follow-up patients requiring ongoing care, workups, including diagnostic testing and examinations. And these are not patients that came to the clinic routinely prior to anti-VEGF agents. Canada, and specifically Manitoba, has a large patient to treating ophthalmologist ratio. We're actually the lowest retina specialist to patient population ratio in Canada at the moment. We continue to train residents and fellows, but the demand outpaces the human resources available. So I think trying to manage the fairly extensive patient load is something that is only going to become increasingly challenging as we move forward.
Ravi, it's not just the expanding population, but it also seemed to be in the forefront of leading treatments for patients who are up north. And really, Manitoba is very well recognized as a leader in treating remote areas. Can you tell us more about this?
Thank you for that, Mona. It's definitely something that Manitoba has a fair amount of experience with. I'm not sure how much of a leader we are, but we certainly are a province where the only major city is Winnipeg, and we're located 45 minutes from the Canada-US border. Outside of Winnipeg, there's one ophthalmologist in Brandon, which is 2 hours west, and the rest of the ophthalmologists are located in the city center. So we still have a fairly large area to cover in northern Manitoba as well as Nunavut and into Western Ontario. So our department has a long history of community outreach, and we basically hire people with the expectation or understanding that people will do fly-in outreach clinics to areas such as Norway House or Nunavut. And our residents actually get experience going to these communities with staff people as well. It certainly is providing care to areas that are underserviced. And the challenge with that, as we all know, is you can't be everywhere at once. So while you go up north to serve these communities, there's a sacrifice to be made for the patients that you're not seeing when you're here in the city. So when I was a retina fellow in Montreal, Matt Tennant, who's a retina specialist in Alberta, he actually approached me with a tele-ophthalmology program. And he said, would you be interested? I think Manitoba is a really good fit. And I said, of course. And I looked at the system, and it essentially used ETDRS guidelines to take 7-field fundus photography using a special 3D technology. And it allowed us to provide one of the most robust virtual eye exams that we could then log into a computer and review these diabetic patients and see which patients had enough severity that they needed to be flown down for treatment. This initiative was for diabetes rather than macular degeneration, and continues to be because we have a large Indigenous population with a high prevalence of diabetic retinopathy over AMD in our northern communities. The ability to provide care to these patients was really satisfying, and I would sit in my little apartment in Montreal during my off time from clinic and surgery as a fellow, and then I would take the patients who needed to be flown down to Winnipeg and talk to my colleagues who were practicing here and ask them if they would take the referrals, and they did. So this program became quite effective. It tripled in size when I moved back to the city, and we expanded the area that the stations were set up in to include the Thompson area and the PAW, as well as the fly-in program into the Island Lakes region. I'm pretty happy with how it is. There's still room for more expansion within city centers as well as east and west. On top of that, we still do outreach clinics for anti-VEGF injections. We were going to Brandon for the longest time, just up until this year. And we still fly into Dauphin, as well as do drive-ins to Kenora region for outreach clinics as well. So there's all sorts of different means of trying to spread ourselves out across a fairly large geographic area. But the good thing is we're able to provide access to eye care in keeping with Canadian diabetes guidelines to populations that otherwise would have gone without any care at all.
It's incredible that you can do all that and still have a busy practice in the city. It's just really wonderful.
It certainly is challenging, but satisfying.
What caught my interest in what you said is that you were able to develop this impressive program during your quote unquote off time as a retina fellow at McGill. Being at McGill, I know how busy those retina fellows work, so I'm just amazed that you're able to do anything productive on your off time as a retina fellow. So one day you'll have to tell me how you blocked off time for retina fellowship, which can be so all consuming. So kudos to you.
Thank you.
So, we read your bio earlier, and it's clear that you spent some time working with the Manitoba government. And I'm wondering why, a busy clinician surgeon like you is feeling the need to work with the Manitoba government to help with access to treatments and technologies for your patients. So can you tell us a little bit more about why you decided to spend time working with the Manitoba government and what some of the challenges and opportunities are that come with this work with the government?
Well, I think if you're around long enough, you inevitably learn that if you want to see change happen, you just have to take the steering wheel. And I was the vice president for the Eye Physicians and Surgeons Association of Manitoba for some years. And was on the board prior to that for many years. And I vowed actually when I started practice that I really wouldn't get politically involved. And that fell flat pretty quickly for the reasons I just mentioned. It was such a good experience working on EPSM. It taught me a lot about healthcare on a bureaucratic level. And the advocacy work for continually trying to raise the standards of patient care, as you're both well aware, is a never-ending task. So learning how to create these relationships with MLAs, MPs, and hospital management is really not a skill that we learn in our medical training. And it's vital. So if we want to actually be patient advocates, learning those skills to effect change becomes something that we just have to do. And I thought it was actually really useful to start learning more about understanding the other point of view and the fiscal constraints that plague our healthcare system. And this is not unique to Manitoba. It's across all of Canada. And we have to be responsible stewards of long-term sustainability of our healthcare system while ensuring that patient outcomes aren't compromised. And that was a really important learning point for me. The challenges of relaying these patient outcomes to those in charge of budgets who didn't always fully grasp the consequences of their decisions and were somewhat myopic was really difficult at times. And I think that learning to navigate some of these challenges, I would say it definitely is a different type of education that I've grown to appreciate and continue to learn from and grow into. I think that at the end of the day, the more we can learn to work with partners, and they should be partners as opposed to adversaries, the better we're going to do for society.
Totally agree with that, Ravi. And I hear from so many colleagues and even feel like that sometimes myself, that we're not equipped to know how to start with some of these challenges. And so what kind of advice would you give to other ophthalmologists that feel like they should be more involved, or there's opportunities to impact change, but they don't know how to start? What kind of advice would you give these colleagues with regards to working with their governments?
One of the first things I would say is there's power in numbers. So we have numerous societies and organizations on a national level, the COS and the various subspecialty societies that we have. And many of our provinces have organized advocacy groups like EPSA, EPSOM, EPSO. So we've got groups to be involved with. And it's easy to think that you're an island, but if you're, I was so pleasantly surprised after running up against a few brick walls that I could actually go to an advocacy group and, working on the COS board, we were called upon to do this and brainstorm to see how we might help somebody achieve a particular goal. And the collective support really does add weight to the message that you're trying to get heard. And so recognizing that you don't have to try to do it alone is really important for being heard. And the other piece of advice I would say is be resilient and persistent, because you'll run up against brick walls, but you do have to just step back, look at it at a different angle, and perhaps ensure that you're not really looking at it from your own angle, but that you have a team of people, because other people bring perspectives that you may not have initially seen, and they might find solutions to problems that you didn't really think of. The work is ongoing. It's admittedly tiring, and it's satisfying, but you have to be able to rely on the people around you so that you don't completely deplete your reserves. So work as a team and recognize that there are many groups around you that have resources, and both financial as well as mental resources to help you achieve these goals.
I think this is a good time to make a shout out to the COS Advocacy Council, which that council is doing great work and always looking for volunteers to join the committee or even just to share ideas. So thanks for mentioning the Advocacy Council, and I certainly commend them for the work that they do.
I agree 100%.
EyeCan wants to know what you think. Please send your comments on today's episode or any suggestions you may have for topics or features to communications@cos-sco.ca, and we will try to incorporate them into future episodes.
Hi, I'm Marie-Claude Robert, and I listen to the EyeCan Podcast.
So Ravi, you studied in Alberta, you did fellowship in Montreal, in Quebec, and now you work in Manitoba. What do you say are the particular challenges or the specific challenges to working in Manitoba?
It's so challenging because I would say that working on the COS actually gave me a better bird's eye view of ophthalmology in Canada, and I was extremely grateful for the time I spent with you all there. Wonderful people, hugely educational, and that's my shout out to all of you. And I'm not sure that it's 100% unique to Manitoba, but we are one of the less well-off provinces as far as financial resources goes. And I mean, after doing a residency in Alberta, it almost is like two complete opposite ends of the spectrum. So approval for new therapies often come late to this province compared to other centers in Canada. One of the big challenges is we are, even though we're sort of central in the country, we are somewhat isolated. Winnipeg's got this reputation for freezing cold winters, even though it was 7 degrees and there's no snow on the ground at the moment. And recruitment has been challenging. It's been great watching our residency program get resurrected. And as a result, we've actually been more organized as an academic faculty, and we've been training fellows in retina, glaucoma, and pediatric ophthalmology. And many of these fellows have actually stayed on as staff. So, it's been great for recruiting more staff. But whenever you make some gains, you have some losses, and we've hit a critical period in our ophthalmology department where some key players have finally said, okay, well, I guess it's time for me to step back. I'm retiring. And so we're actively recruiting. Maintaining your human resources numbers as the group gets older and decides to spend a little bit less time clinically and surgically, is certainly something that is challenging. And it's a different environment that a lot of people simply are not familiar with. So the other shout out I'll give is to Manitoba. It's beautiful, and I encourage people to come and check us out. And perhaps one day we will fulfill that wish list of hosting the COS in beautiful Winnipeg summer.
I hope so too. It would be fun. How many residents are in your program?
We've started off with 1 per year, and we moved to 2 per year every other year. And this year we actually did 2 per year consecutively. It sort of depends on the funding of the PGME and med school. So but we're hoping to just continue on with 2 per year. It's a really nice compliment, and we have a great group.
And being on EPSAM, do you know how many ophthalmologists are in Manitoba?
I think we're at about 26 or 27. Yeah. And the catchment area is, out to Thunder Bay, it's somewhere around 2 million.
Wow.
So, we need some more. Yeah.
Those numbers are drastic, right, Mona, compared to our multiple hundred ophthalmologists here in Quebec, right? So that's... You're working hard, Ravi. Working hard.
It's everybody is busy. So if you want to be busy and work hard, come on by.
Yeah. That's impressive. Ravi, you mentioned earlier that retina care has changed and evolved quite a bit over the last couple of decades, and I'm wondering if you can share with us some of your, whether it's your favorite or just the innovations and advancements that you feel are most important. Or on the horizon that will change the way AMD is managed here in Canada?
Well, it's interesting because there's so many agents for treating AMD coming down the pipeline, and you go to these meetings and they'll actually give you a little summary of what's going on, what stage of what phase of the trial it's at, and there are literally dozens. So we'll see which come to fruition as effective, clinically significant therapies for patients. And it has been fairly stable or sort of even for the last 10 years with little movement in the anti-VEGF arena. But we are seeing some exciting results with the latest agent to come to approval in Canada, faricimab. And it's not currently on formulary in Manitoba, but it is available. I do hope it gets on formulary soon. It's a nice alternative to some of our current treatment agents. And it's nice to have another weapon in the tool chest in terms of treating recalcitrant cases of wet AMD or diabetic macular edema, for which those are the 2 indications for which it's approved at the moment. And if somebody is just resistant to treatment, it's nice to have something else to try. So the more options we have for patients, the better equipped we are to provide them with the best outcomes possible. There's another agent coming to approval at some point, hopefully in the next year, and it's a potential game changer. It's called pegcetacoplan. I'm not sure if you've heard of it outside of retina circles. It's an injectable medication that works to inhibit the complement pathway, and it's shown evidence of slowing the progression of geographic atrophy. So this is the first agent that's been used to address progression of dry AMD really since the age-related eye disease study or AREDS2 studies. It is, as I said, it's not yet approved, but it is approved in the States, and our American neighbors have been using it. And I think there's well over 120,000 injections given. So we'll see by the time it comes to Canada, hopefully we've got some really good real-world evidence from which to draw on and see how it's going to best affect or impact our patients positively. It's certainly going to turn the logistics of managing our patient volumes in the retina clinics on its head. And truthfully, I'm trying hard not to think about it too much because it gets a little overwhelming, but it's coming. So stay tuned.
Like you needed more work.
Yeah, we just need about triple the number of retina specialists.
Do you have any idea when that will be available?
No, I did discuss it with them, and they're saying the last half of next year.
Yeah, I appreciate the impact on your practices. As a non-retina specialist, though, it's so exciting to feel like there's something that I can, offer for geographic atrophy patients, which otherwise, you kind of given the sad shrug of the shoulders and say, that there's nothing currently available to change their outcomes. So this is exciting. We do have some patient listeners, and I'm wondering what you say to your patients with AMD that ask you about any lifestyle changes, nutritional changes. Do you offer them any advice currently?
I always talk to them about lifestyle choices, modifiable risk factors. If somebody is a smoker, I always have a discussion with them about it. I try to impress upon them the impact smoking has on the severity of macular degeneration. I always talk to my diabetics about it. I mean, there's really no upside to smoking. So that's always a discussion. We always review sort of the importance of wearing proper UVA, UVB blocking sunglasses. And then nutritionally, vitamins are great, and the AREDS vitamins have proven some degree of slowdown in moderate or intermediate to severe dry AMD. But I talk to them about the dietary changes, and they do want to know about that. So we talk about foods that contain lutein, the high antioxidant foods that are, I always describe the plates as go for the colorful plates, not the beige plates. Those are the ones that provide you with the best nutrient value. Have some fish a couple times a week. Omega-3 has not yet really proven itself as a supplement for AMD that's effective, but there's no harm. And really, there's so many other health benefits of consuming heart-healthy fats. And there's, it hasn't fallen out of favor to say have fish a couple times a week. So yeah, colorful plates, fish a couple times a week, stop smoking, and wear your UV blocking sunglasses.
So Ravi, I think you're going to support my young children's choice of rainbow ice cream. Does that fit on? Does that qualify as a colorful plate that's good for your health and your eyes?
I'm sure it's delicious.
Another serious question: is there any discussion about hereditary? Do you discuss predisposition to AMD with your patients?
We do review it. I think that there's clearly evidence that there is a hereditary component to macular degeneration. I think what we know now, and especially in the last 25 years, may have some impact in terms of the genetic expression of somebody's AMD, whether they, the children who are now in their 50s and 60s of the parents. Lifestyle choices are just very different, and the education around nutrition and antioxidant-rich foods is really different. In fact, that only came about through some research out of Boston back in, I think, 2003. So a lot of this discussion that we all sort of take for granted as common knowledge really wasn't common knowledge not that long ago. So while I discuss the genetics of it, I do remind patients that genetics aren't really written in stone. And just because your parents may have lost vision because of it, there were certain lifestyle choices that simply weren't well understood in how they impact our vision, especially when it comes to macular degeneration.
Finally, Ravi, we like to always ask our guests when we finish an episode of their outside activities, outside your day-to-day professional life. How do you spend your time? What books are you reading? Do you listen to any podcasts? Do you travel? Any outdoor activities in cold Manitoba? Tell us more about you.
Well, I definitely enjoy being outdoors, and it's almost a bit of a cliche to be a retina specialist who cycles to work, but I do enjoy cycling, and I will bike to work as long as the weather will permit. And I'm a prairie guy, so being on the flatlands, I definitely have a love for cross-country skiing, which is an amazing way to get out and enjoy winter and not be cooped up by it. So being outside cross-country skiing is actually one of my happy places. I'll never say no to adventure travel if possible, if the opportunity presents itself. And I've been fortunate enough to take some pretty fun and amazing trips, from hiking the West Coast Trail and completely disconnecting from the world along the west coast of Vancouver Island, to sailing and kayaking through the islands of Croatia, to looking after elephants in Africa at an elephant sanctuary. So I do enjoy travel, and I wonder whether or not that was just inborn in me through my parents, who immigrated from Trinidad and came to Winnipeg from the islands and started a life here. The last thing I would probably mention, which is completely not adventurous, but I love it, and I could bore you with an entire other podcast, is my love and slight obsession with gardening. And I don't really like gardening things that look or smell pretty. I just like gardening things that taste delicious. So I have a vegetable garden in the summer, and it's one of my most relaxing places to be, and I thoroughly enjoy it, and it satisfies my scientific nerd brain, and it also satisfies my food-loving amateur chef brain, because I love turning what I've grown into really wonderful meals. And I'll leave it at homegrown lettuce is very exciting.
That's fantastic. Thank you.
Ravi, that was a great discussion on an important topic. I certainly learned a lot and really enjoyed it, and I hope our listeners did as well. So thanks for spending the time with us today, and I look forward to the exciting future in AMD.
Thank you for having me.
EyeCan wants to know what you think. Please send your comments on today's episode or any suggestions you may have for topics or features to communications@cos-sco.ca. And we will try to incorporate them into future episodes. Season 4 of the EyeCan Podcast is brought to you by Daghar Ophthalmology. We thank them for their support.
Nous aimerions remercier Bayer Ophthalmologie pour leur support de la 4e saison du balado EyeCan. Thank you from the Canadian Ophthalmological Society.
EyeCan is written and directed by Kim Tytler and produced by John Allaire from Allaire Strategic Works.
EyeCan is available on Apple, Spotify, and Google platforms, and of course, through the COS Practice Resource Center.
Some episodes this season will include relevant links and show notes, so be sure to check episode descriptions to learn more.
Thank you for joining us this week. We look forward to bringing you more episodes.